I'm Dr. Jared Gardner, and I'm here today with Dr. Aubrey Hough, who is a senior faculty member with a lot of expertise in bone and soft tissue pathology, and he's taught me a lot, and is you're a professor emeritus of pathology here at University of Arkansas for Medical Sciences. And recently, didn't you get a distinguished honor from Vanderbilt also?
Yes, they named me a distinguished alumnus of the College of Medicine.
Fantastic. That's awesome.
This is a treatment of joint disease developed over a lifetime of study of the diseases of the joints with the appropriate photographs. Our first section will deal with degenerative joint diseases, which are the most common type of joint condition. First, we will have a picture of a normal joint, a femoral head. The blue translucent color is caused by the normal content of water bound in the protein polysaccharides of the joint. As we'll see, in other conditions, this will be deficient. Here we see a hematoxylin eosin stained section of a normal articular cartilage with underlying bone. We see the faint bluish line at the base of the cartilage above the bone. This is the layer of calcified cartilage which lies on top of the bone. The area is called the tide mark, and it marks the rostral extent of calcification in the cartilage. When the tide mark is disrupted, it can allow vascular tissue from the bone marrow to grow out and destroy the cartilage. Here we see a polarized light photograph of the same slide. We note that the lacunae are the pore spaces for the chondrocytes. Note that the top layer of the cartilage, the fibers are arranged in a radial fashion, whereas in the intermediate and deep layers, they are vertical to the surface. And this is characteristic of the way they're arranged to conduct force. What cartilage does is absorbs force. The water, which is bound to the protein polysaccharides, is split. Its hydrogen bonds are split by the force applied to the cartilage. The water leaves the cartilage depresses, and then when the force is removed, the water re-enters, recombines, and the cartilage swells back to its normal site. This phenomenon goes on with every step and with every pressure applied. Anything that disrupts this normal mechanism will eventually result in disease. Okay. The most common degenerative joint disease is osteoarthritis. The initial lesion is a degeneration of the articular cartilage. This is followed by proliferation, remodeling, and other secondary changes in the subchondral bone, hence the name osteo. In late cases, this may be the most prominent aspect of the disease. It is not primarily related to inflammation. There are two basic types, primary and secondary. Secondary osteoarthritis follows other known diseases, such as inflammatory arthritis, avascular necrosis, and a number of other metabolic diseases. The primary osteoarthritis has no known antecedent condition, and it is genetically preconditioned. Osteoarthritis has several histologic characteristics. One is fibrillation or erosion of the cartilage. The cartilage surface becomes rough. Eburnation means exposure of smooth bone on the joint surface. This is a later finding occurring after the cartilage has been worn from the surface of the joint. Subchondral cysts or pseudocysts are present in the earlier stages of osteoarthritis. They are caused because the intra-articular pressure is allowed to enter the bone marrow under the subchondral bone, resulting in focal necrosis. Osteophytes are osteocartilaginous outgrowths from the joint. There are two ways to look at them. One, they are a response to damage to the joint to spread the pressure the force on the joint out over a larger area, thus reducing the pressure on the underlying bone. The other way is a teleological approach that they're working to limit the motion of this damaged joint. You can take either one of those. Secondary synovitis often exists. This is due to pieces of bone and cartilage coming off the joint and impacting into the synovium and inducing an inflammatory response. Here we see an opened knee joint with primary osteoarthritis. Note that the cartilage, particularly over the surface of the interior surface of the patella, is no longer shiny and glistening. It looks rough. And this is because it is fibrillated. The articular surface of the patella is one of the first places in the body to develop osteoarthritis. It can occur in the 30s decade, particularly people that are athletic. It used to be called chondromalacia patellae. Now here we see an initial stage of fibrillation of the joint. This section is stained with safranin O and fast green. Safranin O stains chondroitin sulfate. So you can see that the chondroitin sulfate has been lost from the superficial cartilage. This means that the capacity to absorb and release water has been impaired. And now this is probably a secondary phenomenon after damage to the cartilage, but it's characteristic. Another thing you'll notice is that where the cartilage is cracked at the surface, there are multiple chondrocytes per lacunae. Once the chondrocytes are unroofed in their little lacunae, they will proliferate. And this, in fact, can release enzymes that make the damage somewhat worse. Here is a more pronounced example. The fibrillation and cracking has occurred, and note that it's down almost to the level of the tide mark of the calcified cartilage. So it doesn't take much more for it to penetrate down into the underlying bone and allow fibroblasts to grow out on the surface and subsequently ossify, producing what is known as eburnation, or a polished, smooth joint. Here we see a phenomenon called Weichselbaum's lacunar resorption. In response to the injury in the crack, and there's a crack at the top, one can see the chondrocytes are proliferating and they are resorbing the matrix around them. This was described in the 1920s, and at one time was thought to be a specific phenomenon, but now we know it's just reactive. Here is one of the absolute classic features of osteoarthritis. Here we see a crack in the cartilage has penetrated into the bone marrow, allowing the interarticular pressure, which is quite high, to penetrate into the bone marrow, producing focal necrosis. Subchondral pseudocysts are very common in the femoral head and the acetabulum, somewhat less common in the humeral joint, but they occur frequently in the hip. What's interesting is as the osteoarthritis proceeds and you develop eburnation in a bony surface, the subchondral pseudocysts become less prominent. It may be painful, but the cysts are less prominent. And what's interesting is these cysts can occur very early in the course of the disease before there is joint space narrowing on x-rays. Okay, here we see another feature of osteoarthritis of the hip. Note that the surface of the hip, which would be at the upper right, has largely been lost. It's no longer round, okay? Oh, it's no longer round, so that this has had a severe loss. And look down at the lower inferomedial portion. See the beak-like osteophyte. Osteophytes grow out from areas of decreased pressure on the edge of the joint, and they're both bone marrow, and a fibrocartilaginous surface. It's not like hyaline cartilage, but it is cartilaginous. Okay, so we can easily see the red staining. This is a Masson stain. The original line of the joint on that side, which is still there, with the new bone laid on the outside of it. So osteophytes are absolutely characteristic of primary osteoarthritis. Okay. All right, here we see another case of osteoarthritis. And note that there are a few osteophytes, but they're not very prominent at the lower right. Okay, now this case also has prominent subchondral pseudocysts. And this case, on the other hand, is not primary osteoarthritis. This is secondary osteoarthritis in someone with long-standing rheumatoid arthritis. And there is a difference, a big difference in terms of osteophytes. And they're also much less likely to go to eburnation. They are more likely to develop a fibrous surface, which can actually unite with the other side of the joint. This is known as ankylosis. It's not all that common in rheumatoid arthritis, but it is absolutely characteristic of ankylosing spondylitis. Okay. Now here we see a gross view of eburnation on the surface. The white area, there's no cartilage. You can see some cartilage, brown around it, but this is the weight-bearing area of the femoral head. Also note that the femoral head is no longer round. It's depressed, and the lower part of the femoral head in the center is an osteophyte. We're just not seeing it in cross-section. The red pits that are on the surface are bone marrow poking through, where it has already penetrated down there. This is severe osteoarthritis. Here we see another area of osteoarthritis, which has undergone what is known as secondary avascular necrosis. This is not like primary vascular necrosis, which occurs in an intact joint in one of several circumstances that we will discuss later. This is someone with severe osteoarthritis. There is no cartilage left over the inframedial surface of the joint here, right? And what's happened is you then have avascular necrosis of the eburnated portion of the bone underneath the osteoarthritis. This is not common, but it can result in very severe and rapid progression of symptoms. Here is another aspect of osteoarthritis, the formation of osteocartilaginous loose bodies. What happens is pieces of bone and our cartilage are sheared from the joint. The cartilage, incidentally, does not die. It can maintain its life in the synovial fluid because it's avascular to begin with. But the bone usually doesn't do that all that well. But this is from a knee joint, an osteocartilaginous loose body with osteoarthritis. Here we see another aspect of osteoarthritis, which is the formation of a reactive synovitis at the edge. Here seen of the reddish tissue along the edge. This is due to impacting pieces of bone and cartilage with a foreign body reaction in the synovium. Okay. Here we see a villous synovitis with comparatively little inflammation occurring in an individual with chronic osteoarthritis. In contrast, this is the villous synovitis of rheumatoid arthritis, which has hyperplasia and hypertrophy of the synoviocytes and lymphoid aggregates in the synovium. Quite a difference. There are known risk factors for osteoarthritis. Obviously, it increases with increasing age. Female gender after age 50. Obesity. It's complex, but obesity is associated with increased osteoarthritis of weight-bearing joints, such as the knee and the hip. A major joint injury, particularly one which a fracture which penetrates into the joint space. Congenital or developmental abnormalities, particularly of the hip, and there are a number, such as congenital hip dysplasia, Legg-Perthes disease, which is necrosis of the growth center in childhood, and so forth and so on. Slip capital femoral epiphysis, that's 3. And also the immune crystals, hereditary metabolic factors, Here we have gout, pseudo-gout, and a number of other conditions which can be associated with crystals, including hemochromatosis. There are some that are probable: repetitive joint use, such as occupational use. There are a number of studies, such as in professional soccer players in Europe, people that have had fractures, people that have jackhammer operators developing osteoarthritis of the wrists and fingers. The other factor is dense bones. Osteopenia, thin bones, is associated with less osteoarthritis. And to think about this in a teleological sense, it's because the bones themselves are more pliable and absorb a greater proportion of the forces applied over the joint than a person that has heavy bones. In fact, there is a traditional sort of phenotype of individuals, particularly males with osteoarthritis, is that they're not so much, they don't have to be they're not obese, but they're muscular, strong-looking people that develop osteoarthritis of the hip. There is conflicting evidence as to whether smoking and diabetes or whether estrogen use in postmenopausal women may retard it. In diabetes, the problem is that they have what is called browning of cartilage. The elevated glucose, the cell things that causes the hemoglobin A1C to rise, it's also glycosylating the protein polysaccharides in the joint. Now let's talk about and give some other examples. This is generalized osteoarthritis in a 17-year-old beagle. And note that there's osteophytes on the spinal vertebra, osteophytes at the hip, osteophytes at the knee, osteophytes at the shoulder joint. So it's a generalized osteoarthritis in an aged geriatric dog. This is a classic type of hereditary parent of osteoarthritis in humans. This is a Heberden's joint. Heberden's joint is an osteophyte of the distal interphalangeal joint. They are far more common in women, and genetic studies have shown that the disorder, it's a polygenic inheritance, acts like a autosomal dominant in women and autosomal recessive in men. Also in this slide, you see something else which is characteristic of osteoarthritis, but not as pathognomonic as the distal interphalangeal joint, and that is a Bouchard's node of the proximal interphalangeal joint. These are osteophytes. The spine is also affected by osteoarthritis. And here we see two good examples of osteoarthritis of the spine with encroachment on the spinal disc seen in the middle of the photograph, and osteophytes in two adjacent vertebrae, where the disc is ruptured and is producing an osteoblastic response. This can produce spinal stenosis, certainly can do a great deal of pain and require surgery.
Are they actually connecting there? Is it like ankylosis or no?
No. We'll see that in another. They are not connecting. There is a condition, now that you brought that up, in which they do connect, and it's not inflammatory. It's called ankylosing hyperostosis, which is a variant in the spine of diffuse interstitial skeletal hyperostosis. It is strongly associated with diabetes, type 2 diabetes, and believe it or not, is very, very common in a couple of Native American tribes. Secondary osteoarthritis results from degeneration of joint structures brought about by some other antecedent condition. The characteristics are it's often severe, but not infrequently localized, in contrast to primary osteoarthritis. And the big thing is that osteophytes are not prominent. Here are some common antecedent conditions to secondary osteoarthritis. the crystal deposition diseases, gout, pseudo-gout, necrosis or abnormality in subchondral bone, such as avascular necrosis, avascular abnormal joint laxity, such as Ehlers-Danlos, osteogenesis imperfecta, or Marfan syndrome, abnormal cartilage growth or function, congenital hip dysplasia, achondroplasia, synovial-induced destruction of cartilage and bone, rheumatoid arthritis, and various joint infections. Okay, gouty arthritis is uniformly associated with hyperuricemia, but interestingly, most people with hyperuricemia do not develop gout, and only some who develop gout develop real joint disease from gout. It has several phases. One is an acute inflammatory arthritis. It's very painful due to urate crystals within the joints, which have been phagocytized by granulocytes. There are asymptomatic periods between attacks. This is known as intercritical gout. Then finally, chronic deposition of urate in and around the joints form tophi. Now, one can have sort of all three of those at one time, but that is the classic breakdown of the disease. It was one of the first metabolic diseases described in Great Britain during the 1880s.
Was gout more common in the past, do you think?
Yes, like the diet made it common.
The diet, okay.
Eating eels and kidneys and things like that. Here we see the classic polarized light picture of the synovial fluid in acute gout. The needle-like crystals are not only present in the synovial fluid itself, but they're actually within granulocytes. This produces degranulation of the granulocytes with an appropriate immune response. This is a section through a toe, through a metacarpophalangeal joint with a large tophus. Here we see a tophus in the edge of the vertebral body in the intervertebral disc. This slide has been cleared by running water over the section of the spine, flushing out the bone marrow and making everything else that's left very apparent.
So just water does that?
Just water.
I was going to ask you how it was made. That's amazing.
Yeah. Okay. Here we see a histology of a case of acute gout. Either acute or chronic gout. We see macrophages and granulocytes surrounding these amorphous deposits. The amorphous deposits had urate crystals in them, but urate crystals are very soluble in dilute formaldehyde. Unless one acidifies the formaldehyde, they will all dissolve. Another way to do it is to not fix the specimen in formaldehyde at all, but fix it in 70% alcohol, which will not dissolve them. Here we see severe chronic osteoarthritis resulting from gout. I know this is gout because I have a section of it to show that it's gout. Here we see the section, and this blue material down in the below the destroyed joint surface is all tophus material, or was. The calcium crystal-induced arthritis is more than just gout. It's a constellation of findings due to deposition of calcium pyrophosphate in and around the joints. More uncommonly, the crystal is basic calcium phosphate, which is often called hydroxyapatite. That's relatively uncommon. Mostly it's pyrophosphate. You're usually over 50 years of age. It's the same pathogenesis, phagocytosis of crystals by granulocytes with release of enzymes. Acute exacerbations can lead to chronic osteoarthritis. And it is much more common to lead to osteoarthritis of the knee than it is of the hip. Faint calcification in the periarticular tissues is characteristic of the syndrome. Can also affect the spine. Here we see a case of calcium pyrophosphate deposition disease, or pseudogout. And if you'll look at the amorphous material, look at the little holes in the material. You see the little clear areas. Those are pyrophosphate crystals. And here they are. They're a rhomboid-shaped crystal, not needle-like, and they are positively birefringent, which means they rotate a beam of polarized light to the right, and urate rotates it to the left. The therapy for these two diseases is completely different, and hence it's wise to make the diagnosis. Here we see a synovial fluid from an individual with pseudogout, and right in the middle there you can see, there's one, over to the right, you can see crystals deposited within the granulocytes. Next, we're moving on to avascular necrosis, I believe. We see it on the left, and what's characteristic about it is it looks like the surface is actually separated from the cartilage. I mean, from the bone. Next line. And in fact, that has happened. The necrosis always occurs. There's usually a narrow band of viable bone right underneath the cartilage, probably because it derives some nutrition through the basal layer of calcified cartilage. Avascular necrosis of the femoral head is a rather common disorder. It has several antecedents, although most of it time it's idiopathic. The reason that you have avascular necrosis of the hips and of the femoral heads is based in the embryology and anatomy of the femoral head. The femoral head is fed by penetrating vessels from the surface, but it's also fed by penetrating vessels coming up through the femoral neck. When they get to the area of the old physis or epiphysis, they turn around and go back where they came from. So in elementary physics, if the velocity is plus v and then is minus v, at some point it must be 0. And that is where the clots occur. Here we see a whole mount section of avascular necrosis. You can see it's been present for quite some time. Note that the femoral head is more or less shifting to the left. You've lost volume on the right, and it's shifting to the left. There was a European technique of many years ago. They didn't do total hips. They went in and did an osteotomy and rotated the new part back up into the acetabulum. It doesn't work all that well.
So this is dead bone here, right?
Yeah, the area that you see the crack and everything in there.
And this new sclerosis forming around the dead bone?
Yeah, it's walling itself off. Thank you. That's characteristic. It's walled off by productive bone beneath, trying to short. It senses the weakness. Now here's another cause of severe joint disease: ligamentous laxity. This is a person with Ehlers-Danlos syndrome, which is a defect in elastin. There's 7 different types. Most of them produce joint disease. Now, here's one of my favorite slides. Remember the 17-year-old beagle? This is a 2-year-old German Shepherd with congenital hip dysplasia. Note that first of all, that the acetabula are quite flat, and they're not, looks like the femoral head cannot fit inside there. Then look, there's severe osteoarthritis of both femoral heads and the acetabulae, but the rest of the joints are normal. This is a classic picture of secondary osteoarthritis. Okay, now here we see a human joint with a human femoral head with congenital hip dysplasia. First of all, It is small. Look at the shaft. Look at the width of the shaft. Compare that to the rest of the femoral head. Normally, the femoral head should be about 3 times the diameter of the shaft. It's only about 1.5 or less because it's not very big. So this is congenital hip dysplasia. This is more common in female children than male. It's usually bilateral. Can be diagnosed very early in life with x-rays and can be treated. If you allow the child to come up and walk and develop the degenerative disease, it is a really bad problem. Okay, this one shows severe osteoarthritis. Next slide, please. Associated with acromegaly, the overgrowth of the fingers and hands. And what happens in this condition is that the cartilage continues to grow. The base of the cartilage has epiphysis-like properties. And with somatomedin being produced by the growth hormone excess, it continues to grow. So they develop severe osteoarthritis, particularly of the spine. Okay. And here we see a costochondral junction in an acromegalic. And look, it looks just like an epiphysis. This is an adult acromegalic, and it should be very quiescent. You can see it's got the columns and the proliferation of an active epiphysis. Okay. Achondroplasia also develops severe osteoarthritis. Here we see a bone from an achondroplastic. Next slide. And this is a disease which most people don't recognize causes severe joint degeneration. Ochronosis, alkaptonuria. Ochronosis is the tissue manifestation of alkaptonuria, which is the excretion of homogenetic acid. And you can see it deposits in cartilage. It combines with the protein polysaccharide, producing, it interferes with the water binding capacity, makes the cartilage very brittle, and it's easily abraded from the joints. You can see it here in the ear cartilage. Okay, next slide. Here we see what I'm talking about. Note that there are areas where the cartilage is already gone from the articular surface of the patella. It was all black and it's already been washed away. These people develop severe detritic synovitis too from impacts in the synovium. Look at the osteophytes in the spine, or the breakdown of the spine. All right. Okay. This is another cause of secondary osteoarthritis. Note that there appears to be some eburnation. But what's interesting here is look at that blue tissue at the top. That would normally not be normal. That would not be normal to have that. There would not be that blue tissue, a big plug and a hole there. Also notice that the femoral head itself, you can't get a really good look at the size because we don't have the shaft, but it's not all that big. And there are no osteophytes. This is juvenile rheumatoid arthritis. So that's pannus. The blue is pannus. A lot of people don't believe me when I say that you can look at the whole mount slides and you can diagnose these diseases about 99 times out of 100. Okay. Okay. Now, next slide, and I'll tell you what this is. This is severe osteoarthritis, and here is a radial head. There's some synovium removed with the radial head, and it is reddish brown. So what would this be? Is
it rheumatoid arthritis?
Hemophilia.
Oh, hemophilia. Wow. I've never seen an example.
And it actually is deposited. It's red. It's deposited in the bone too. There's actually iron deposited in the bone marrow.
Wow.
And the synovium itself. This is an interesting disease. Years ago, I studied this in a series of papers, including in vitro work and tissue culture. And although they develop pannus, which can be destructive, the real damage is done by the iron itself, is phagocytized by the chondrocytes, and they die. So the cartilage disappears from the joint very early, and it's not I mean, of course, they're having intra-articular hemorrhage, but it disappears very early.
Is that what's going on?
That's what this is.
So that's all hemorrhage in the joint
That's
space?
that's an acute hemorrhage and hemophilia. All right. Here we see a histologic section of the same thing that we showed, the radial head, and it's stained for iron. And you can see the iron is actually deposited in the bone marrow. The pressure inside the joint will do that. And look at the synovium attached to the joint on each side. It's totally blue. Continuing on, in inflammatory arthritis, there's destruction of cartilage and periarticular bone, which then results in secondary changes leading to arthritis. The sine qua non of this particular disease is synovial inflammation. The synovial inflammation, many of these diseases form what is called a vascular granulation tissue called pannus. Pannus is from the Greek word for apron, and this spreads over the joint. And we'll see examples of how the enzymes released from the pancreas, released from the pannus, result in resorption of cartilage. The pannus also activates cytokines, some of which come from the cartilage cells themselves. Pannus may be infectious, post-infectious, or autoimmune. Suppurative bacterial arthritis is less common than it formerly was, but it still occurs. The most common in this country is gonococcal infectious arthritis. It's most often seen in the wrists or around the hands. I don't have an explanation for that, but it's very characteristic. Salmonella arthritis is frequent in people that with sickle cell disease or who've had splenectomy. The key in the sickle cell disease is the autosplenectomy, so that plus the fact that they have gastric achlorhydria. The gastric acid is the first line of defense against the salmonella bacteria. Staphylococcal is by far the most destructive. This can occur in a number of situations, and unfortunately in this country today, it most often follows IV drug abuse. Haemophilus influenza can cause septic arthritis in young children. What's characteristic of inflammatory arthritis from septic arthritis is the marked polymorphonucleoleucocytic infiltration of the synovium. You do not see this in rheumatoid arthritis. In rheumatoid arthritis, there are lymphocytes, which are predominantly T lymphocytes in the synovium. Next slide. Here we see the subtle staining of a gram stain showing the gram negative diplococci characteristic of Neisseria gonorrhea. It's subtle, and you have to really look for it. We have antigen tests now for this to make this less important than it formerly was. Several of the tick-borne disorders can cause infectious and post-infectious osteoarthritis, including Lyme disease. And Lyme disease, so-called because the first cases were described around the Lyme River in Connecticut, has an acute, subacute, and chronic phase. And in the acute phase, you actually have this spreading area of inflammation. Stage 2 disseminates, can cause meningoencephalitis, cranial neuritis, heart block, pericarditis. Stage 3 is a destructive chronic arthritis, acrodermatitis, atrophicanes, and neuropathy. By the time you get to the destructive third stage, it closely resembles another disease, which is also a spirochete, which we no longer see much in this country, tertiary syphilis, because the organism is Borrelia is a spiral organism. Okay. This is one of the things that's interesting about the chronic joint conditions with them is that they have the same plasmacytic infiltrate and thickening of the capillaries that you see in tertiary syphilis, as that you're seeing here. And here we see a silver stain, and they're hard to see, but it's the same thing. It's the same thing. There they are. Okay. This is a Steiner stain, and it shows the spiral organisms in the infiltrate. This is a good disease to treat in its acute phase, for sure. Now, this is a subject that everyone going into pathology needs to be very cognizant in their practice. I have seen some real disasters caused by the failure to recognize that an individual might have Mycobacterium tuberculosis in bone and joint. The most common site is the spine. The next is the hip. It characteristically involves both synovium and adjacent bone. One of the characteristics in the knee or the hip, it easily crosses the cartilage barriers, unlike septic bacterial arthritis, and frequently involve both sides of the joint. Produces destructive pannus, but with typical granulomas and giant cells. May be confused clinically with other arthritides easily. And here we see a hip joint with Mycobacterium tuberculosis. You see on the upper left the pannus. You can see it has destroyed the cartilage and is now in the subchondral bone in the middle of the slide. And it looks at low power, well, maybe this is rheumatoid arthritis, but at high power, as we'll see, it is characteristic as to what it is. With the characteristic giant cells of Mycobacterium tuberculosis. And here we see a Ziehl-Neelsen stain showing that the pannus is teeming with acid fast bacilli. You have to remember that you only see between 1 in 1,000 and 1 in 10,000 with the characteristic stains. So that it's just teeming with them. Okay. Probably the most common inflammatory arthritis in this country is rheumatoid arthritis. It was originally described around 1906 and separated out from osteoarthritis. It's fairly common. It affects about 1% of the US population, which would be about 3 million people. The female-male ratio is 2 to 1. It is strongly associated with HLA-DR4 and with a couple of other DWs and DQs. But what's interesting is the concordance in identical twins is only 30%, whereas the concordance of ankylosing spondylitis in identical twins is virtually 100%. So what does this mean? This means that there is a genetic predisposition to rheumatoid arthritis, but it takes a second hit, probably an infection. There are several that are potential, an infection to produce the disorder. Whereas in ankylosing spondylitis, whatever, if there's a second hit, it is so common that everyone gets it. And the current feeling about that, it is Klebsiella in ankylosing spondylitis. All right, we can't see that well enough. Okay, rheumatoid arthritis attacks the hands. But unlike osteoarthritis, where you have the distal interphalangeal joint swellings, here it's the proximal interphalangeal joints and the metacarpophalangeal joints particularly. You can see in the x-ray how there's a lot of bone destruction in this case with invasion of the pannus into the bones. And therapy in rheumatoid arthritis has to be directed toward keeping this from happening because a person is really no longer functional. The first autopsy I ever did by myself, I was between my junior and senior year in medical school at Vanderbilt. I did a case at the VA, and he had severe rheumatoid arthritis, and he also had what was then called secondary amyloidosis, now would be called a.k.a. amyloid, the kidneys. And individuals with rheumatoid arthritis are prone to develop amyloid-associated protein type amyloid, particularly if they're not well treated to control the inflammation. And the reason for this is the a.k.a. amyloid is a polymerization of a protein called amyloid A antecedent, which is produced in the liver under the being driven by the IL-1 level. So if you have inflammation and do not control the IL-1 level, you're prone to develop this. This also occurs in a number of other diseases, including ankylosing spondylitis. Characteristically with rheumatoid arthritis, you have ulnar deviation at the fingers. And when you get to this stage, you really don't have much use of your hands. RA is an immunodysregulation disease. The T lymphocytes respond to type 2 collagen and superantigens, releasing cytokines, including rank ligand. If you'll recall, rank ligand also is involved in stimulating osteodestruction. The B cells produce autoantibodies, especially IgM rheumatoid factor. They also produce another class of agents which are directed against various peptides that are present in synovium. And they're actually more accurate for the diagnosis of RA than is rheumatoid factor. Macrophages localized to rheumatoid factor complexes, producing a type 3 injury, activating complement. Also release monokines. Okay. So the pathology of RA in the synovium has several characteristics. There's a hypertrophic villus synovitis, they have lymphoid aggregates, vascular proliferation always occurs, fibrinoid necrosis may be present, it invades cartilage and bone and some pannus, and the numbers of CD8 suppressor cells when you do sensitive studies are reduced. Here we see an absolute classic of what a gross picture of hypertrophic villus synovitis and RA looks like. Here we see a low power photomicrograph again, lymphoid aggregates, vascular proliferation, synovial hyperplasia. I don't see the fibrinoid necrosis, but that certainly can occur. Here we see areas of fibrinoid necrosis in the synovium in a person with severe rheumatoid arthritis. Note that you do not see granulocytes in the synovium. You see lymphocytes. You can see granulocytes in the synovial fluid, but not in the synovium. If you see granulocytes, be thinking about something else in the synovium other than rheumatoid arthritis. Now, another thing which occurs in rheumatoid arthritis is the formation of so-called rice bodies. Rice bodies are little bits of necrotic tissue which are floating around in the joint, caused by this piecemeal necrosis of the low-grade vascular disease that they have. This is an olecranon bursa, which has been removed and contains the rice bodies. They're characteristic of RA. Now, they can occur in infectious diseases too, but they occur in RA. All right, now, this slide shows you almost everything you need to know about the pathogenesis of joint destruction in RA. Here we see a metacarpophalangeal joint. And on the right, we see pannus, the vascularized granulation tissue. Okay, and it has resulted in the loss of cartilage from the joint. Then there is a collision zone with cartilage, and something very amazing is happening in the collision zone. The chondrocytes are proliferating and resorbing their matrix even when they're not in direct contact with the pannus. This is because of the cytokines being released from the inflammatory response in the pannus. Here we see a later stage of pannus in which it is down now in the subchondral bone and eating out the bone and producing lytic lesions. Now, rheumatoid arthritis also has some rather striking extra-articular pathology. Rheumatoid nodules, which are present usually on extensor surfaces, are manifestations of the same smoldering vasculitis that you see in the synovium. Rheumatoid vasculitis itself, which can be a relatively devastating phenomenon, pleuritis, pericarditis, and tendinitis. This is a rheumatoid nodule. On the there are several here on the yes, on the surface. There's another one. There's another one up here, right there. Yeah. So these are interesting. One almost never gets one in its acute stage. In its acute stage, there's a venulitis and thrombosis, which is followed by the characteristic palisading. Here we see what the rheumatoid nodule looks like, in that they are palisading inflammatory cells, macrophages surrounding it, and then an area of fibrinoid necrosis seen in the center. The early rheumatoid nodule is quite vascular and then undergoes this change. Similar nodules of this type can occur in the myocardium, in the pericardium, in the lungs, on tendons, for sure. Thank you. Now, here we have a rheumatoid nodule in the lung, okay, of a person with severe rheumatoid arthritis. Rheumatoid nodules are always associated with rheumatoid factors, IgM, usually high titers. Only about 25% of people with adult rheumatoid arthritis have rheumatoid nodules, and that is a group that is a poor prognostic group. Now, here's a late rheumatoid nodule, and this one's in the heart. And if you didn't look at it very carefully, you'd say, well, it just looks like some old infarct, but it is a rheumatoid nodule. There's a residuum of the palisading down at the lower left. Okay. Now, here's an interesting one. This is a pericardium with rheumatoid nodules in this person presented with tamponade from fluid in the pericardium. They took a pericardium. This is one case from Nashville, and it shows rheumatoid nodule. And unlike the joint, where the center of the nodule cannot shell out and form a rice body, that's what happens here. The center necrosis is out in the fluid. There are three types of rheumatoid nodules in the pericardium: the specific type, the semi-specific, and the non-specific. And this made a very nice paper in the American Journal of Medicine for me back when. Okay, so pericardium. This is rheumatoid vasculitis. It is a very small degree of a very small caliber of arteriole, precapillary arteriole, and they have fibrinoid necrosis with swelling of the endothelium. This is usually a somatic, not a splanchnic vascular disease, unlike polyarteritis nodosa. And this next picture sort of shows the caliber of artery that you see in the various conditions. And you can see that, trying to see the.
I guess this is arterial.
Yeah.
Probably be in this stage.
Yeah, it's small vessels. It's almost like the cutaneous leukocytoclastic vasculitis. It's very similar. I don't think I could tell them apart. Okay, now this is a foot, obviously. Look, the tendons normally are nice and clean and shiny. They're not. They're all covered in what is essentially granulation tissue. The tendons of the feet and of the knee and of the hand and the elbow are sheathed. The tendon sheaths are synovium. So they're affected by rheumatoid arthritis like anything else. And so several things can occur in the feet. You can get rheumatoid nodules, but this is actual rheumatoid tendonitis in the feet. If you think about the symptomatology of rheumatoid arthritis, one of the first things to occur, if not the first, is morning stiffness. And this is exactly why. It's not so much the joints, it's the tendons surrounding the joints that are stiff until you break up those adhesions that have formed the night before. Okay. All right, another situation which occurs in rheumatoid arthritis is spinal disease. Radiologic studies show well over half people with RA do have some disease in the spine. Here's a severe example. Here we see the lower left, the odontoid or dens, tooth process. And we can see several things are going on. First of all, the articular space of the atlas, the axis articulating with the atlas is a true synovial joint. And look at the hypertrophic villus synovitis. You can see it on the other side too. All right, so what happens is the suspensory ligament of the atlas is eroded so that the atlas, it carries the atlas forward when the neck is bent. So that without this, the atlas stays posterior and can impinge on the spine, resulting in severe problems, including sudden death. Also in this particular one, I believe there's also rheumatoid granulation tissue in the dens itself. And you can look through with an open mouth view, lower down, up, right there. You'll look through, it used to be radiology, and where's the dens? Gone, or partially gone. All right. And here's what I'm talking about. See the pinching of the spinal cord. Now that's a C2 on C3. C1 on C2 would be a little higher, but that's rheumatoid arthritis. Now, juvenile rheumatoid arthritis, sometimes known as Still's disease, is a heterogeneous group of disorders. Only 10 to 15% of them are true juvenile presentations of RA. It's called the polyarticular variant. They start out with multiple joints involved, and unfortunately, most of them go on to develop adult RA in adult life. 25 to 40% are juvenile presentations of seronegative spondyloarthropathies, the classic one of which is ankylosing spondylitis. It's called the pauciarticular variant. And then 40 to 60%, in other words, half at least, are febrile presentations with a rash. This is the systemic variant, it remits, are true Still's disease. And they have fever, and they're pretty sick. This is chronic adult type, this is chronic juvenile rheumatoid arthritis. You can see that the cartilage has been eroded, there's pannus, and you have severe disease of the hip. Conditions associated with RA. Amyloidosis in 10 to 20%, usually the a.k.a. type. Sjogren's syndrome in 10 to 15%, including an increase in the incidence of malignant lymphoma. Anti-DNA antibodies, 10 to 20%, usually not the classic anti-double-stranded DNA of SLE. Felty's syndrome, which is a syndrome of hypersplenism, granulocytopenia, and marked cutaneous vasculitis, which is devastating. And I used to say there are ways to tell between Felty's syndrome and Sjogren's syndrome is that a Sjogren's syndrome tends to have mild RA, so they will walk in to see you, but the Felty's syndrome will be carried. It's severe RA, high levels of rheumatoid factor, and other anti-DNAs. Cryoglobulinemia, Raynaud's phenomenon, not very common. Raynaud's phenomenon is more common in progressive systemic sclerosis or mixed connective tissue disease. Okay. Amyloid. Amyloid in itself is caused by a number of chemical of different substances. They all have in common two things: the ability to fit and form a beta plicated sheet, and the ability to rotate a beam of polarized light. In other words, they're asymmetric. And they have to fit into that sheet in a certain way or they can't fit in. And of course, the classic one is light chain amyloid, caused by only a highly conserved group of usually lambda light chains that have a highly conserved group of about 10 amino acids. The average, most of them can't do it. But rheumatoid arthritis is a.a. amyloid, which is amyloid-associated protein.
The outer circle, like a slice of liver.
Yeah, with amyloid.
Wow.
So amyloid's very characteristic. It affects the liver, spleen, kidneys. Here we see amyloidosis of the kidneys. It produces a thickening and replacement of the glomeruli with no inflammatory activity whatsoever. Clinically, this is characterized by a high level of proteinuria at a very early stage. It's slowly progressive over a period of years. Sjogren's syndrome is characterized by two of the following: xerostomia, which is a dry mouth, keratoconjunctivitis sicca, dry eyes, and a deforming arthritis or some other connective tissue disorder with rheumatoid factor. This could include just about any of them. It's a secondary type with RA is common. The primary type without RA is uncommon, but more severe. It's associated with DR3. This is a salivary gland with infiltrate of lymphocytoid plasma cells in this condition. Of course, these people are also prone to develop what used to be called Waldenstrom, but now lymphoplasmacytic lymphoma, particularly the primary ones. Felty's syndrome, a group of clinical and laboratory findings, including severe granulocytopenia and anemia, diffusing enlarged spleen, severe, often fulminant RA, and erosive leg ulcers. It's a vasculitis of small arterioles, increased number of large granular lymphocytes and NK cells. And they are prone to develop a natural killer cell positive lymphoma, leukemia. Increased incidence of both cryoglobulinemia and lymphoma. Poor prognosis compared to RA or Shelty syndrome. Very poor, Sjogren. Here we see the severe leg ulcers in Felty syndrome, and here we see the massive splenomegaly. You can't see yes, you can see the ruler down there. And this look like a spleen that may be about 25 to 30 centimeters in length. So it would be probably over 1,000 grams. And as usual, there's no distinguishing features. It's just a total homogeneous spleen. Rheumatoid vasculitis can produce necrosis with or without cryoglobulinemia. It's uncommon, and it's a very, very small type of arteriole. Now here's a comparison of rheumatoid arthritis with the so-called seronegative spondyloarthropathies. They're called seronegative because they don't have rheumatoid factor. I just think they're now called spondyloarthropathies. But the classic one is ankylosing spondylitis or Marie Strumpel arthritis. Affects young males predominantly. 90% are positive for HLA-B27. Some non-Europeans that have it are positive for B7. Less than 1% have rheumatoid factor, so it's down where we can go into the department here and start taking blood from people, and we'll find some people with rheumatoid factor because it's non-specific. 25% have iritis, which is not present in rheumatoid arthritis. 10% have aortic insufficiency. It's strongly familial. It's been described in up to 5 generations with 100% concordance in monozygotic twins. The current feeling on this is that these people have increased rates of carriage of Klebsiella in the gut. And there is some common reactivity between Klebsiella enzymes and Klebsiella protein in this. And it's not a good disease, but it's treated fairly treated well with anti-inflammatory agents and a lot of exercise mobilizing the spine where it can't ankylose. This is a classic picture of ankylosing spondylitis in the spine. The spine is straight and it has bony bridges along both sides of the spine. Here's an example of iritis, which you see the iris diaphragm is no longer round because of the synechia which have developed from the inflammation. Reiter syndrome is basically sort of a variation on ankylosing spondylitis. They start with an acute synovitis. They have chronic changes in some, sacroiliitis, like ankylosing spondylitis, but it's usually unilateral. They have an ascending lower extremity arthropathy. That's characteristic. They have ossification and enstesopathy. Enstesopathy means inflammations of the insertions of tendons on bone. They have non-specific mucosal inflammation. It can occur along with ileal, colonic, and urethral inflammation. Again, the Klebsiella is implicated here too. And of course, chlamydia. It was originally described with chlamydia. Here we see another person with iritis and irregular iris diaphragm.
Is it conjunctivitis too?
It's and conjunctivitis, which occurs in Reiter syndrome. Sure does. Real conjunctivitis. Organisms implicated in Reiter syndrome are Shigella flexneri, Salmonella, S. typhimurium, Yersinia enterocolitica, which is one which gets a lot of attention, Campylobacter jejuni and Campylobacter foetus, Chlamydia trachomatis, and Ureaplasma urolyticum. Okay, this is the worst type of arthritis you can get. You can see the fact that he has the psoriatic lesions on the fingers, and you can see the destruction, which we'll see in another picture in a moment, I think. These people tend to have actual erosion and destruction of the distal phalanges. And I'll show you why in a picture here. Okay. What happens is the synovium in the fingers, the synovial tissue reflexes along the bone. And so the inflammation of the psoriatic arthritis follows that and actually causes resorption of the middle of the bone. So they can have a hand that's like an old-fashioned drinking cup. It just collapses. And it's a severe type of arthropathy.
So is that right here? The bone is getting resorbed?
Yeah, it's been resorbed. Yeah, I think you could look a lifetime and never find that.